We are honored to have Professor James Dear as our next speaker from University of Edinburgh, who will speak on biomarkers of paracetamol toxicity. Professor Dear is a globally renowned expert in clinical pharmacology and toxicology with pioneering work in paracetamol toxicity and novel biomarkers. And on a personal note, he has been my mentor for my PhD, and I can say that he is not only an exceptional scientist, but also a deeply inspiring individual. Over to you, James.
Thank you, Kavinda. Well, thank you very much for the invite. It's been a fascinating meeting so far. And to be honest with you, the speakers so far have said a lot of what I was going to say. So I will try to sort of move on to new things relatively quickly. So I'm going to talk about the markers we use, the markers we could use to identify people who are at low risk or at high risk of bad outcomes after taking paracetamol. I'll just get rid of this bit as well for you. There we go. So I think the first question is why bother? What's the real interest in paracetamol? And I think there's two sides to paracetamol that are important. There's the workload, the number of patients who overdose on paracetamol. But this is obviously predominantly adults, but children as well. And the point here is that paracetamol overdose is common. And it's particularly common in the United Kingdom, where I come from. And here's some old figures you'll see on the slide. From 2018, the number of people attending hospital after an overdose. And these are absolute numbers, and you see that quite proudly the United Kingdom is the leader there, even though our population is substantially smaller than, say, America. So the first point to make is that paracetamol overdose is common. And so if you go to the emergency department in the UK, or indeed in most countries, you're likely to see somebody who's taken paracetamol. In the UK, it's as common as having a heart attack. Now, that rate of paracetamol overdose varies across the world. So on this slide, I've shown the rates, for instance, in Saudi Arabia, because I was recently giving a talk at Tox, and it's substantially less common in Saudi Arabia. And on this next slide, you can see the rates of paracetamol poisoning per 100,000 people. Some work done by colleagues in Australia. And I don't want to go too much into what the different coloured dots mean, but essentially there's a variability in how common paracetamol overdose is across the world, with Australia being common, the USA being common, and other countries being substantially less common. Ethiopia, for instance, Africa is much less common. But it's a worldwide phenomenon, and it's common. Now, my colleagues already who have presented before me have described how paracetamol causes liver injury, so I don't need to dwell on this. But just to reiterate the point that it's a metabolite of paracetamol that is the problem, and we don't have a good tool to measure how much of that metabolite has been made. So we measure the parent drug, paracetamol, where actually what we're really interested in is the metabolite. And the acetylcysteine, NAC, the antidote we use, replenishes glutathione, which protects the cells against the toxic effects of the metabolite NAPQI. But others have already talked in depth about that. And also people have touched on how we risk assess at the moment in the UK and indeed in other countries. But I'll just go through this just briefly again to sort of highlight some of the current challenges we have. And this is very much from the point of view of seeing lots of patients across lots of hospitals across the world. So in the UK, we use a line that starts at 100. So as Angela said, remember, this is the paracetamol concentration measured in the blood against the time from overdose. And we start our line at 100 milligrams per litre, and it decays at a rate of 4 hours, even though the half-life isn't 4 hours of paracetamol. Other more sensible countries like the USA, Canada, Australia, New Zealand start their line at a different place at 150. Don't be put off that the line is straight, because that's a log scale. But basically, if you're over the line, you get treatment. If you're under the line, you go home. That's how we do it. So let's imagine a couple of patients. Let's imagine Mr. Orange. So Mr. Orange here is just over the line in the UK. has got a normal ALT. So ALT we're using as a readout of hepatocellular liver cell damage. So normal liver, just over the line. In the UK, treat with NAC. In Australia, say, don't treat with NAC. And then we go to Mr. Pink, who's way over the line. And we can all agree he's over the line, whether he's in Australia, USA, wherever he is, way over the line. And his liver's injured. That's necrotic liver on the slide. His ALT is very high. So we treat again. But the point I want to make is we give the same treatment to both these patients. We give them NAC. And maybe sometimes we give a higher dose of NAC to somebody else than somebody else. But the truth is we do the same for both. And that really can't be right. It's very questionable whether Mr. Orange needs treatment at all, and in fact doesn't get treated in Australia. Whereas Mr. Pink clearly needs treatment, is clearly at risk of death, but we do the same thing. The other challenges we have are that this assessment's quite time consuming. You're reliant on sending bloods up to the laboratory and then waiting for the laboratory to do the tests, then get the blood back, and then find a doctor to look at the blood results, and then go see the patient to make the action and prescribe the drug. And that all takes time. We know in the UK that the time from somebody checking into the hospital to starting NAC is about 5 hours on average. Why does that matter? Because we all know that the sooner you give NAC, the better. But we have delays in the system. With this approach, we're very dependent on the patient's history. We are dependent on asking the patient, when did you take the overdose? How long did you take the overdose over? How much did you take? As Angela highlighted very nicely. And there's going to be subjectivity in that. Some patients, we won't get a history. Some patients' history won't be correct. It's always going to be a degree of subjectivity. And I've also said there's a high number of false positives. What I mean by that, and I think this is very important, is we are over-treating patients. But a lot of patients we give treatment to do not need it. The problem is we don't quite yet know which ones are which. So, as I've said, we use paracetamol concentration and ALT to assess risk. Where does this come from? Well, this is some data from many years ago, back in the 1970s, where we didn't have NAC. So no NAC, you just measured the paracetamol and see what happens. And essentially here we've got different nomogram lines, starting at 100, going 100 to 200, 200 to 300, 300 and above. These people did not receive any treatment. And what we see is, unsurprisingly, as your paracetamol goes up, your risk of liver damage goes up. Quite obvious, the more paracetamol there, the bigger the risk. I think it is worth just noting, though, that in all countries, we would treat over the 200 line. I don't think there's any controversy about that. But, you still see out of 52 patients, only 3 people died. That's still 6% mortality. But the vast majority of people, or the majority, 94% of people, did not die. You go up to over the 300 line, the massive overdose, which, no question, we would talk about as a serious overdose. It is still worth noting that 89% of people survived a massive overdose. So when it comes to interpreting observational studies, case reports, it is worth just bearing in mind that most people will survive these overdoses if you do absolutely nothing. Okay, so then we've got another way of looking at this. If you give NAC and you increase up the paracetamol nomogram line, even with NAC, the rate of liver damage goes up. So paracetamol, higher it is, the worse you do. ALT, when you come in, actually it's got some value in the sense that this is a paper we published many years ago. It's got a lot of flaws. I'm not going to pretend it's perfect. But I think the point it makes is, if you start NAC in a patient and their ALT is normal, they're probably going to be fine. And I think that still holds true, that if you get NAC in before liver injury is apparent, the chances are the patient will do well. And this is highlighted by the high negative predictive value of a normal ALT in this study. So what this combination of paracetamol and ALT has led people to do, which I think is pretty neat, is combine paracetamol and ALT into what's called the multiplication product. So the idea of this is paracetamol over time falls. So you take an overdose, your paracetamol starts high, and then it falls over time. and the half-life's about 3 hours. If you get liver injury, over time, your ALT will go up. And if you get significant liver injury, it's about 9 hours for it to double. So one goes down, one goes up. If you multiply one by the other, you'll get a value. And that value will be high if your paracetamol's high, or if your ALT's high, or if a bit of both are high. And this is a nice risk prediction tool because it doesn't require you to know the time from overdose, doesn't require you to know basically any history. Doesn't matter if it's a staggered overdose, doesn't matter if it's a single overdose. So let's give some examples. So what we're doing here, just to reiterate, is we're simply timesing paracetamol value by the ALT. So if you've got a low risk, so let's say a paracetamol of 50 and ALT of 30, so 1,500, I think that is, what you see is you're very unlikely to get liver injury. You're very unlikely to go on and develop liver injury if you're treated with NAC. That's the caveat of these. The sensitivity is nice and low, or high, sorry, 98%. So a low value, going to do well. A high value, say with 10,000, so your paracetamol is 200, your ALT is 50, then your specificity is high. You're likely to go on and get liver damage. So it's a nice tool. It's a nice sense check to times one by the other, and it gives you a risk. And I do that in my head. It isn't used in guidelines yet. It is used in clinical trials. It's not used in guidelines yet, but I tend to do it in my head every now and again, as it gives you a nice sense check about risk. If it's below about 1,000, it's low risk. If it's above about 10,000, it's high risk. The problem with the paracetamol ALT product is there's a big area in between low risk and high risk where it doesn't perform as well. There's quite an indeterminate risk area. But nonetheless, it's a useful tool that's a nice sense check that doesn't require knowledge of the pattern of overdose or the timing of overdose. And there's more to come in that space, I think. So Angela's done some lovely work on adducts, which I think are excellent research tools. So what's an adduct? So paracetamol, as we've already heard, is metabolized to NAPQI, and NAPQI is highly reactive and it sticks to proteins in hepatocytes, and from that causes damage. You can measure NAPQI bound to protein in people's blood. So what you measure is paracetamol, and it's often stuck to a cysteine amino acid. And you can measure that in the blood, and that is a marker, if you like, of paracetamol reactively binding to protein. And it's a marker of the amount of toxic metabolite produced and the amount of liver injury. And Angela showed very nicely indeed that if you measure these, when the patient comes into hospital, you can predict who's going to get liver toxicity really quite accurately. So they're a very nice tool. What they need, and it is in development, but what they need is an assay to be able to do it in hospitals. I think adducts are particularly useful in the setting of patients who have acute liver injury and the cause is not clear, because the adducts have a longer half-life than paracetamol itself. So when the paracetamol's all gone, the paracetamol adducts may still be detectable. So it's very useful to determine the cause of someone with acute liver injury where it's not clear. Problem with adducts is, stating the obvious, they only work for paracetamol. They don't necessarily work for other causes of liver damage. So while they've got an important use case for paracetamol, they don't expand out to other causes of liver damage. But obviously, lots of different drugs cause liver damage, and that's led to a lot of work globally to develop new markers for liver damage. This is driven actually not specifically by paracetamol, but actually more by idiosyncratic liver injury, which is a big challenge in drug development. And lots of markers have been proposed. These are the ones that are going through to regulatory approval. There's microRNA, there's mitochondrial nuclear injury. I'm going to talk today a little bit about this marker keratin 18 and some of the work we're doing. But there's others, there's markers of inflammation like osteopontin that are being taken through to the FDA and the EMA to be improved within the use case of drug development. So what we started doing a little while ago now is trying to make a point of care test for these markers. So one of the challenges with new markers is you have to show that they work. I have to convince you that this blood test does something useful. But the other side of the coin is you need to have an assay available so that doctors can use it. So we've shown repeatedly that, say, a marker like microRNA 122 is highly effective biomarker. My friend MIR122, we spent years working on, is elevated in patients who get liver damage very early. It's very specific. But microRNA 122 doesn't have a point of care test, and it's very hard to make one for microRNA. So we, a few years ago, realized that, for this to have any value to anyone, we need to have tests available that people can use. So what we tried to do is develop a rapid, cost-effective, so we're making this cheap, point of care, so it can be done at the bedside to get away from that idea of sending the blood up to the lab, waiting 2 hours, and it can be done in low and middle income settings to identify patients who are at high risk for us to treat with different treatments. And the marker we chose was a marker called keratin 18. You don't need to know too much about it. Keratin 18 is a protein that's released from injured liver. It's released from necrotic cells. It's highly expressed in the liver. It tells you about cell death. It's supported by the FDA to use in clinical trials. So drug-induced liver injury is, I'm going to call DILI on these slides. And here's a slide that looks a bit scary, but all it's showing basically is if you go down this way, that's patients with increasing ALT. For each of these tiny rows is a patient, and this is people ALT increasing. And across the bottom, you've got a range of different plausible markers of liver damage that we've measured in this multiplex study. And here, and yellow is up. So the more yellow it is, the higher it is. And what you see is as you go up ALT, well, no surprise, ALT goes up. That's obvious. That's defined. And we see K18 goes up in everybody who ALT goes up in. And then as you go down to the other markers, you do interestingly see one or two where it doesn't go up as much. So K18 goes up in people with an ALT rise. We know that. And we know from multi-center studies that K18 goes up when the person first presents to the emergency department, and it goes up before ALT. K18 goes up. So we're pretty robust that lots of studies have shown that K18 is a marker of liver damage. So here's a real case. Patient, 25-year-old man, took 35 grams of paracetamol at 2:30 in the morning. He put it on Facebook, which shows how old this slide is, but he put it onto Facebook, which confirms the timing. So we don't think the timing's wrong. But again, it comes down to this story about the importance of the history. He was assessed 4.5 hours after the overdose, and his paracetamol level was 107, which was below the nomogram at that time. He had no liver damage, and he was discharged. He saw psychiatry and was discharged. So there's his paracetamol, there's his ALT, INR. He was below the nomogram. We believe the time is correct. He was discharged. That's entirely right. He came back to hospital because he felt unwell. He had abdominal pain. He was vomiting. His paracetamol had fallen, but his ALT now was 11,000 and his INR was 2.1. So he's in trouble. He's got acute liver injury with a pretty significant INR rise. He says he's not taken another overdose since leaving, which I believe. His paracetamol had fallen probably appropriately. So what we did was we took his blood when he first came in and we measured K18. And what we see is K18 was clearly raised. There's about 8 times the upper limit of normal. So clearly identified liver damage in this person that was missed by the current guidelines or the guidelines at that time. So there's a case where this marker would have picked up someone who was sent home These cases are very unusual, it doesn't happen very often, but it shows that it's sensitive, or it highlights its sensitivity. And the other thing, just to remind you, is why do you want to pick up liver damage early? Because we know if we start NAC, we know that delay to NAC is associated with more liver injury, as Angela said. And the take-home message is, if you start NAC 3 hours earlier, you reduce by about 15% the risk of developing liver toxicity. So we know that we need to start NAC soon, but somehow that doesn't really translate. So K18, sensitive marker, we want to identify liver damage early, so let's get on and do it. The challenge was, or is still, that K18 is measured by an ELISA. That's the reference standard test that's used. ELISAs, as anybody who's done them in a lab will know, take time. It's a great ELISA, it works really well, but it takes more than about 3 hours to do, even if you're an expert. And that's too long. There's no point waiting 3 hours. We need a test that's quick so doctors can decide what to do. So what we've done is we've made a lateral flow test that I'll come on to, with the objective of using a finger prick of blood and giving results in about 20 minutes. So you'll all be familiar probably with lateral flows by now. Lateral flow is what we measure in COVID, in pregnancy tests. How does lateral flow work? Well, just simply, sample goes on a sample pad. In our case, a drop of blood. Case of a COVID test, swab of your mouth. Case of a pregnancy test, a drop of urine. It then goes along and it picks up nanoparticles. These nanoparticles are coated in antibody. If the target protein, in our case K18, is present, then as it goes, the nanoparticles diffuse along the membrane and will bind to the complementary K18 antibody. So the nanoparticles will stick there. So that's the line you see. What you see with your eyes are the nanoparticles. If there's no K18 or very little there, the nanoparticles carry on their journey and they all stick at the end. So that's the control line that you see on a lateral flow. What you're seeing are the nanoparticles. What I'll come back to here is the trick that we've done is we've added a Raman reporter tag to the nanoparticles, but we'll come back to that in a moment. So here's some real examples. So top batch, you can see the ALT values here of somebody who's taken a paracetamol overdose. Here's some true, real lateral flows. And we see nice control lines. And we don't see any test line. So one line, no liver injury. That's great. And we see the K18's low on the ELISA. That's great. Then we take patients with liver injury and we see 2 lines. These are real samples, real tests of them. And we see the control line. Now we clearly see a test line and the ALT's up and the K18's up. So that's brilliant. We can prick the finger, we can run a lateral flow. 1 line, you're fine. 2 lines, you've got liver damage. Job done. But you've got to be careful with these kind of studies because these are phenotypic extremes. So these are patients who have got no liver damage, for sure. These are patients who have got pretty significant liver damage. I mean, look at those ALTs, they're way in the thousands, and we pick them up. But what we want to know is what's in between. And then what we knew from the start was there's going to be a grey area because K18 is in all of our blood. It's just it goes high if you've got liver damage. So there's going to be a grey area. We can see this here. Here we've taken some normal serum and we've spiked K18 in. And as you go up, you get to this middle area where, well, there's a line there, there's a line there, there's definitely a line there. But there's this kind of grey area where, well, where does the line start? And what we would say is if you're above about 100, you've got liver damage. If you're below, it's getting questionable. So there's going to be this grey area. So we knew from the start we were going to have to be able to quantify to actually better measure the K18. And to do this, we made the first clinical grade handheld Raman reader device. Looks just like this. And basically, I won't go into details, but you clip the lateral flow in, press a button, and it tells you how much K18 is actually there. And that's using the fact that the nanoparticles in this lateral flow are coated with a Raman reporter. So what do? Prick the finger, run the lateral flow, pop it in the meter. Takes about 30 minutes, the whole process. And basically we get these readings and we can distinguish liver injury from health, and we can say how much cateins there. So that's what we do. Let's see if show you some evidence it does actually work. So we started off in serum that we'd frozen and stored from patients. That was our starting point. So here we did a study where we took 200 patients, 100 with no liver injury, 100 with liver injury, and we ran lateral flows in triplicate. The people running them were blinded to whether the patient had liver injury or not. There's one of the researchers with all the lateral flows next to him, showing how many lateral flows they had to do. And what we see, I'll just take you through this slide slowly. If you look at the lateral flow by eye, it's actually very sensitive, i.e., if you have no line, if you just have the one control line, no test line, it's actually pretty good for ruling out liver damage. But as we knew, if you see a line, the specificity by eye falls off. That's probably a bit low. It's probably a bit better now with refinements to the strip. But we know specificity falls off, i.e., there'll be some people with a faint line, you'll say, oh, I'm not sure if it's positive or not. If we then use the handheld reader, we see a much better performance. We see sensitivity at 95%, we see a specificity at 88%. If you like rock curves, it's a rock curve of 0.95. Basically, when we use the lateral flow and the reader, works very well. Another way of showing this sort of data is to say, okay, what happens in the study? There's two studies. I won't go into detail. We'll take this one for an example. 50 patients with liver damage, 50 without. If we make the cutoff on the lateral flow 108, so we say above 108 disease, below 108 control, we then look at the ALT values. If we're above 108, 47 have liver injury, 6 didn't. If we're below 108, 44 did not have liver injury, 3 did. So that's the kind of performance we're getting. And if we stack that up against all the other studies of K18, we see that the ROC curves using the ELISA are listed there. The ROC curve using our device, much the same. So far, so good in serum. So then obviously what we want to do is measure it in blood. So to start off with blood, we've embedded the trial within another, we've embedded the device within another trial we're doing, which is a trial of cell therapy to try to regenerate the injured liver. I won't go into any detail about this. It's other than to say it's for people who've got established liver toxicity, and we're giving macrophages from a donor that are alternatively activated as a cell therapy to go to the liver to regenerate it. But what it gives us is a group of people with liver damage where we can embed the device and see, does it measure liver damage in blood? So here's the sort of headline data. Got a few patients, each of those different colours is a patient. You've got different visits of the trial, and you've got some people who never had liver damage. If you look at ALT, well, unsurprisingly, when you go to the trial, the ALT is high and it falls. Look at K18 on the ELISA, it's high, it falls. Look at K18 in serum, which is what I just showed you, it falls. But now we're looking at it in blood. So this is a finger prick onto the ELISA, does it work? Onto the ELISA, onto the lateral flow test, and it works. So we're pretty confident that the lateral flow test will detect liver damage, because there's all the people who haven't got any liver damage. And when the liver gets better, it'll follow it. But what we really need to do is the definitive trial. So we've got the lateral flow, that's the lateral flow in its packet, and we've nearly finished this study. This is a regulatory study where we've put the lateral flow device into the emergency department, and we're using it to say, does it detect liver damage in real patients? Doing it in 5 hospitals across Scotland, and the primary endpoint is looking at liver damage or not using ALT. I won't go into too much detail. It's going now. It'll hopefully finish in the next few months, and we'll see the performance of the device. It's likely that the performance of the device won't be as good as it was in the lab. I'd be very surprised if it is. Question is whether its performance is fit for purpose. And we're recruiting patients. That's where we expect to finish. So just finally, one of the things I highlighted too is that this is a lateral flow test. So it's very cheap. And lateral flows by the World Health Organization they meet the assured definition for a point of care device. They're affordable. They can have few false positives, few false negatives. They're user friendly. They require minimal training. They're robust. We've trialed this device in Uganda and it worked fine, even when kept at room temperature in humid, hot conditions. They don't rely on that much equipment and they can be easily shipped and cheap. So we've started to think about using this device in other contexts, because remember, K18 is a measure of liver injury. It's not a measure of paracetamol. It just tells you the liver's damaged or not. It doesn't tell you why. But one of the things is I mentioned about this reader, this handheld Raman reader, that you need to an extent, and that's very expensive. It's never going to be available where this test is most needed. So we've replaced the handheld reader with simply a phone. And basically, the short answer is if you use a phone camera, so you put your lateral flow there, you put your phone there, you press and take a photo, and then there's some software that converts it into concentration. To be honest, it's not far off as good as the Raman reader. So here's the same data you saw before, but now we're using the phone. Here's people without liver injury, people with liver injury. And again, you see pretty clear separation between the two just by using the phone. So now we can replace the reader with a phone if you need it. And the target market that we're going for is TB treatment. So as you'll all know, probably much better than me, one of the most common causes of liver toxicity in the world is antibiotics, and TB medicines nearly all can cause liver damage, can cause DILI. So we're doing this study at the moment in Uganda and South Africa. We hope to start doing in Bangladesh as well. So here's some examples of real lateral flows, real patients. Here's the ALT values. These are all patients in clinical trials on TB medicines. And we see the nice control line, but when you start to get an ALT, you see it there really at 120. But as the ALT goes up, you see a test line. So the device works in the field in patients with TB. If you do it just by eye, so remember this is a test we can probably get down to $1 per test. By eye, actually, it's not bad. Sensitivity 87%, specificity 80% for liver damage or not on TB medicines. But if you combine it then with the smartphone, it gets even better. So that's work we're trying to do. Difficult to get funding, but we're trying to take forward to take this from just paracetamol into what is a bigger, much bigger use case, but comes with different challenges. So I'm going to stop there. Many people to thank who've done all the work. Happy to take any questions. And thank you again, Kavinda, for inviting me to this really interesting meeting. Thank you all.
Thank you very much, Professor James Dear, for your excellent, very comprehensive presentation. I'm sure it is new to most of us, and hopefully, I hope that will change the management of paracetamol toxicity, in the years to come with your, introduction of these newer devices that will help detection of paracetamol toxicity early. So thank you very much, Professor James.